on Dr. Mellinor to discuss how COVID-19 changed dengue management. Good evening, Dr. Ang.
This cartoon image depicts what is dengue to us. Our hands are full with the COVID-19, and now with rainy season, it is here to haunt us. We have these concerns about the impact that significant co-circulation of the dengue viruses and COVID-19 could have on our healthcare system. I do lecture for pharmaceutical companies, but this talk is not in any way connected with them. I'm pretty sure that these are the questions lingering in your mind as of the moment. So, aside from the differential diagnosis, there is always a possibility of co-infections, and it is still not yet known whether these co-infections will lead to a greater severity or can result to complex and unpredictable consequences. With these joint epidemics, it can lead to several collateral damage. So this should be a point of vigilance among us doctors. It is somewhat comforting that data from the CDC showed that cases of dengue and COVID-19 for children are for most part mild cases. So it lessens the burden in our part. This would be the outline of my talk. We'll be discussing outpatient management, inpatient management, and then dengue cases that we had with co-infection. So as we go along, let us see if dengue management changed in times of COVID. The outpatient management for both is almost the same. Those patients who deemed to be stable and follow-ups are assured either by telemedicine or face-to-face checkup can be taken care of at home. However, it will differ in the isolation protocol. We all know that for dengue, we don't need isolation precaution, but for COVID-19, this is a must. On times that they are still on viremic or symptomatic phase, and that would be the first 10 days. So do we do isolation protocol in dengue? This actually depends if RT-PCR was done, awaiting results, or highly suspicious of COVID co-infection as well. But if we follow the interim COVID pathway from the WHO of May 2020, those whom, if suspicious of co-infection, they have to be isolated. For both of them, symptomatic treatments such as antipyretics for fever and pain, and then appropriate rehydration is actually advised. I think some of the LGU house these asymptomatic COVID-19 patients, but that would be according to the LGU protocol. Regarding multivitamins and minerals, this was lifted from the PIDS-P guidelines, but I guess if these kids are given balanced, healthy diet, supplements are not warranted. As a review as well, the cores which we are after are the warning signs for dengue, which occur after defervescence. And for COVID-19, the median time for dyspnea would be 5 to 8 days and 8 to 12 days for ARDS, and ICU admission of 10 to 12 days. These are the warning signs and symptoms in dengue that we should be wary of. For the inpatient management, we admit those patients on dengue with or without warning signs and those in Group C who presented with shock. On COVID-19, we also admit patients under moderate, severe, and critical. From the WHO, dengue initial screening labs are the following: Results will depend on the day of illness and also if it's a primary or a secondary infection. In secondary infection, usually IgG is already high from the start as opposed to primary infection where it will start to rise at a later date. For suspected cases of COVID-19, according to the WHO protocol collection of upper respiratory tract specimens, nasopharyngeal and the oropharyngeal, for testing for reverse transcription polymerase chain reaction or the RT-PCR. When we say virus testing, usually it tells you who is infected at this moment in time and can give you an opportunity, of course, to act and then respond appropriately. SARS-CoV-2 antibody tests are not recommended for diagnosis of a current infection with COVID-19. I'm sure you've heard of rapid antigen tests, or rather, the rapid lateral flow antigen test. This test is sensitive to detect infectious people who have the disease, so they have low analytic sensitivity but with high frequency testing. It's low cost but with rapid results. As per DOH memorandum, rapid antigen tests shall be allowed for diagnostic testing of suspect. So mainly, it can be used in the hospital setting when RT-PCR capacity is insufficient, where the turnaround time is also critical to guide patient cohort management. I saw this article in the DOH website that Baguio City is chosen for a pilot use of antigen test. So we wait for this paper to come out as well. As no new guidelines, still standard precaution is adapted for dengue and isolation precaution is instituted for COVID-19. Airborne precaution for those aerosol generating procedures like your intubation and their suctioning, and whether dengue will be isolated as well with a possible COVID-19 that is likely to coexist. This would be according to the hospital policy, so it's institutionalized. In dengue, we already have the guidelines from the WHO and the PPS guidelines, so it's judicious because we use this guidance to a good judgment on the IV fluid titration. However, for COVID-19, according to the WHO, use cautious fluid management in patients without tissue hyperperfusion and fluid responsiveness. So just enough fluids is needed. We are careful or we exercise caution in COVID-19 because aggressive fluid resuscitation may worsen the oxygenation, especially in the settings when there is limited availability of mechanical ventilation. Both disease entity entails the use of isotonic solutions. So for group B patients with coexisting condition or comorbidities, you may or may not start your IV fluids. It will depend on the patient's hydration status and then of course the circumstances. I am sure you're all familiar with these algorithms we use for dengue with warning signs. Start your IV fluids, then you titrate down accordingly through, of course, with your clinical assessment improvement. Also, these algorithms are used for compensated and hypotensive shock. Again, to reiterate, compensated shock, we give the 10 mils per kilo to run for an hour, then you reassess for improvement. But for hypotensive shock, we give 20 mils per kilo over 15 to 30 minutes. Then again, reassess if it improved or not. Then titrate it accordingly. For dengue patients, we do request for electrolytes, blood gases, and organ laboratories like your liver function and the renal panel, depending, of course, with the severity of dengue. We also do 2D echoes. We do procalcitonin or blood culture if warranted or thinking of a concomitant bacterial infection. However, for COVID-19 presenting moderate, severe, or critical, so aside from these laboratories, we also add inflammatory markers. In shock patients, we always employ O2 at 10 to 15 liters per minute via your non-rebreathing mask. For COVID, oxygenation is given for SATs less than 94% and then weaned accordingly. No treatment for dengue, or rather, only supportive treatment. But in COVID-19, there are experimental drugs that are used. This is from the PPS and the PHP guidelines, antiviral treatment, which includes remdesivir. And these are the adjunct treatment options. So what happens if they coexist? What is worrisome for us clinicians is the lack of experience of their combined effects. So there are international reports that we are already seeing the coexistence of both disease, but I will present to you clinical profiles of patients that we had in our institution. This is a case series of dengue patient admitted at our institution, also confirmed COVID-19 by RT-PCR. We've seen a decline of our dengue admissions since the pandemic, and to calculate, it's approximately 4% of our total dengue admissions and 6 to 7% from the total COVID positive admissions. The COVID response team, along with the ICC of our institution, mandates that patients with the Ccfd symptoms are triaged to be admitted at the COVID ward if admission is warranted. CCFD stands for cough, colds, fever, and diarrhea. Clinical profiles of these patients, mostly male, age ranging from 4 to 17 years old, and they are admitted on the day 5 of illness and they present with shock. Those in shock have hemoconcentration and thrombocytopenia. Some have chest x-ray findings of pneumonia, and there were no adjunct treatment given for COVID. Our institution is not a COVID referral center, thus remdesivir or tocilizumab is not available. However, most of them were given antibiotics since they also presented with shock. We did organ laboratories as well as inflammatory markers for COVID-19, but most of these labs were non-contributory. And 5 out of the 6 were discharged. They are discharged, of course, according to the WHO and then the PPS guidelines. However, we had one mortality. He is severely malnourished with cerebral palsy, and then, of course, the patient is bedridden for most parts. This patient presents with a GA bleed on admission with a BP of 0. It also presents with severe acidosis and then refractory shock, fluid resistant as well as catecholamine resistant. Patient was given hydrocortisone. Vasopressors were instituted as well as the antibiotics. Eventually intubated, and then we contemplated giving of IVIG. However, the patient succumbed to death within the 48 hours of hospital admission. So did we change our dengue management? No, but we are more cautious of co-infection. With more exposure to this probable tandem, we might have better chance of treating them accordingly. So let us all be vigilant and let us be optimistic, of course, with good outcomes.